Good morning. I'm here with my good friend, Dr. Michael Deeb from the University of Michigan. Michael and I were comrades in arms through the entire core valve family of trials. And just recently, Michael presented the TAVR and SAVR data from our expanded use trial. And one of the questions that raises is if we can put a TAVR in a failed surgical valve, does that change our indications for what age we should start biologic valves? Michael, what are your thoughts on this?
Well, I think that has validity. I think that basically what I do to patients is I present them all their alternatives. And in the United States, in this day and age and in our society, the one thing that young people don't want to do is be restricted by Coumadin. Probably the only salient feature of a mechanical valve is that it lasts a long time, that the probability of you between your first and second procedure is longest if you have a mechanical valve. That is the only salient feature. It doesn't give the good hemodynamics. You have to take Coumadin and all the complications with Coumadin. And so the salient feature is the length of time between your first and second procedure. If you can take a tissue valve, and the tissue valves out that we have today give you an average of about 12 years, somewhere between 10 and 15 years, and you can add 10 years or you can actually double that, you will give the patients the same salient feature that they have with the mechanical valve, yet you'll have the added features of the tissue valve of better hemodynamics and no need for Coumadin and all the complications and issues that are associated with everyday Coumadin. So I think this is a very valid point that you present to young patients.
Well, let me ask you another question. So one of the things that we've done in surgery is we've done a pretty good job of generating data about what happens to our patients long term. And we talk to our patients about how long it takes a biologic valves to undergo structural valve deterioration, and we tell them it's related to their age. And if you're a little bit older, we often tell these people if you're in your 70s, the odds of being free from structural valve deterioration at 15 years is really pretty good. But now we're doing valve and valve, and it seems like some of the numbers are actually shorter than we might have quoted in the literature. Do you think that the numbers we have are really valid, or some of these people just never coming in when they didn't have a valve and valve option, and now they have a valve and valve option, they're coming in earlier with structural valve deterioration? Are we going to have to revise our numbers for our surgical valves?
I don't think so. I think what we're seeing is a patient population that's skewed at the lower end of the bell curve. And I think the reason that we saw that patient population is because they're the patients that had patient prosthesis mismatch. They had the worst hemodynamics. They had the highest residual gradient, the highest flow turbulence, the highest mechanical forces on that valve to cause deterioration. So I think the key issue here with a tissue valve is that you put in a size appropriate valve for the size of the patient. And if you have to enlarge the root or whatever you need to do to get a good match for that patient, I think will give you the best hemodynamics and the longest durability. So I don't think that in that series that we had that we were misquoting patients. I think we were seeing the lower end of the bell curve. I think as time goes on and we increase that patient population of TAV and SAV, that duration between the initial operation of TAV and SAV is going to increase.
So you and I have both done this for a long time. We've seen a lot of surgical valves come and go. Some of them we thought were going to be really great valves, and they didn't turn out to be as good as we thought. And then you and I have been deeply involved in the TAVR trials. I think in some of these TAVR trials, we've generated some of the best evidence we've ever generated for valve disease with our randomized trials. The data we have in TAVR, if it was applied to a surgical valve, would have led to approval for whatever we wanted to use it for. Do you think that the restrictions on TAVR remain appropriate, or should we move to more of an objective performance criteria that you and I are used to in the approval of a surgical valve?
No, I think we should stay with what we're doing with the transcatheter valves. I don't think that the trials that we did for surgical valves were as scientific. I think that that's one of the reasons we still have so many questions about durability, function of these valves, is because all we had to do was show the short-term safety and efficacy of these valves and then some short-term data. And by the time we went to look at long-term data, well, a new valve came in and the old valve was gone. I think that what we're doing now should be a benchmark for the future for any valvular trials that are out there. And I think that we should continue the pivotal and partner trials up to 10 and 15 years so that we can get the true durability of these valves.
When I look at what you and I have been able to do in the world of valve disease. There have been a lot of things I've been able to do that I've found exciting, and I'm sure there's been a lot of things that you've been able to do that you find exciting. And TAVR, for me, has been one of the more exciting things that I've done. And one of my worries is as technology gets better and it gets easier to implant, how do we keep particularly our young surgeons and our young faculty involved as implanters and controlling the destiny of this rather than getting shoved to the side? Any thoughts on that?
I'm interpreting what you're saying is that as the ease of this, as these become more easily implanted, that it'll go away from surgeons and more towards interventional cardiologists. And how do we keep our young surgeons involved in this? Well, I really think that as time evolves, more and more procedures that are being done in open surgery are going to be done in transcatheter technique. Any of the valvular surgeries that are done, a lot of the aortic structural surgeries that are done. If you look at the area in our field, in cardiovascular medicine, that is the most rapidly growing, it's in structural heart disease therapy and in vascular structural therapy. And most of these forms of therapy are going more towards transcatheter therapy. And so, therefore, I think what we have to do in the future is stop thinking about surgeons and cardiologists and start thinking about how are we going to train young physicians so that they can be fully equipped to take care of cardiovascular disease and not get pigeonholed in some silo like, oh, you're a vascular surgeon or you're a cardiac surgeon or you're a cardiologist. At our institution, only cardiologists do this. I mean, no young person wants to go $250,000 in debt in medical school, do 6 to 8 years of training and come out and not have a future. So I think what we really have to do is break down those silos, become more collaborative, become more of a cardiovascular healthcare system, get rid of departments, become programmatic, and train cardiovascular physicians. Those physicians who specialize in cardiovascular disease, who know diagnostic skills, who know interventional skills with wires, who know open interventional skills, so that all cardiovascular physicians are trained to take care of the disease process and not have to compete with all these small little silos.
Well, Michael, I have to say I fully agree with you on that. I think we're moving towards cardiovascular teams, and the team members are going to have specific things that they do within that team, and it really won't matter that whether you're in a department of cardiology or cardiac surgery or vascular surgery. There'll be a cardiovascular specialist. I also have to say that working on TAVR has been one of the highlights of my career, not only because of the exciting technology, but getting to meet people like you and the colleagues you and I worked with. Truly one of the great thrills and highlights of what I've done. So thank you so much for all we've done.